All right, good afternoon, everyone, and thank you for joining us. This is the third event in our Heart Month lecture series, so we appreciate all of your participation on this. Today, we are lucky to have Dr. Kenneth Wojnowski, our pulmonary and critical care and sleep medicine doctor, and the topic for today's presentation is why sleep matters, the relationship between sleep quality and heart health, which is a topic that is very important and I'm sure very relevant to everyone. So with that, one more announcement. We will take questions at the end, so feel free to use the Q&A function. That's how we'll be taking questions, and then we will get to questions at the end. So with that, Dr. Wojnowski, thank you very much. I will turn it over to you.
Thank you, Simone, and thank you everyone for logging on today. Really excited to be giving this lecture because this is a topic that's of great interest to me and I think should be of great interest to many people. When you really boil it down, if the average person sleeps about 6 to 8 hours per night, you're spending almost a fourth to maybe 1/3 of your life asleep. So if we do something that often throughout the course of our life and spend that much time throughout the course of our life sleeping, it has to be very important. And sleep really does affect every organ system in your body, and it has wide-ranging effects, some that we don't even know about. So we'll go through some of those details during this lecture, and hopefully at the end of this lecture, we'll all understand why sleep is so important, not only to our heart health, but to our health in general. So the objectives for today, we'll discuss the normal physiology of sleep and circadian rhythm. We'll review the effect of short sleep on cardiovascular health. We'll examine the effect of obstructive sleep apnea and cardiovascular health. And then we'll give you some tips for quality sleep and how to improve your sleep overall.
And Dr. Wojnowski, we're not seeing your slides.
Okay.
Yeah, they look okay.
How about now?
You're seeing it, Jeff?
Yes.
Oh,
I see the objectives, yeah.
Okay.
And you
All
see
right.
introductions?
Let's just be me. I'm seeing from the Q&A box that others are seeing it. So, all right, carry on.
All right. So the American Academy of Sleep Medicine and the Sleep Research Society recommend at least 7 hours of sleep per night for the average adult. Despite the recommendation of 7 hours of sleep per night, there's considerable variability to what each individual needs to maintain vitality and well-being. I'm sure everyone knows the friend who sleeps 5 hours a night, wakes up in the morning, feels great, very well rested, never naps. That person is different than the average person in terms of what the majority of people in the world need. Environmental factors also play a large role in what amount of sleep is actually obtained. So shift work, whether you work the night shift or second shift, familial obligations. So families with young children often have roles that need to happen in the middle of the night that affect their sleep. And also social and recreational opportunities that affect how much sleep people get. So not only is sleep quantity important, but sleep quality can also have effects on the cardiovascular system and on cardiovascular health. And I would argue that the most common cause of poor sleep quality is likely obstructive sleep apnea, and we'll talk about that later on. Symptoms of short sleep duration or poor sleep quality may include, but are not limited to, daytime sleepiness. So this is the body's inability to resist daytime sleep. These are the people who fall asleep unintended while waiting in the waiting room at a doctor's office, while at a movie theater watching a movie, who sit on the couch when they come home from work at 5 p.m. and fall asleep for 20 minutes. These are all examples of daytime sleepiness. You can also have daytime fatigue. I like to separate fatigue from sleepiness. Fatigue is mostly low energy, tiredness, but not sleepy. Sleepiness is the inability to resist daytime sleep. Patients with short sleep duration or poor quality of sleep may also have lack of alertness or vigilance, poor or slow reaction time, and they can have impaired mood. So our new normal is considerably different than what it was 100 years ago. So in the year 1910, Americans averaged 9 hours of sleep per night. And in 2014, so just over 10 years ago, Americans were averaging 7.5 hours of sleep per night. So the average American nowadays sleeps considerably less than the average American did 100 years ago. And you certainly can look at our world today and understand why. We have cell phones with text messaging. We are always available. Our business hours don't end at 5 p.m. We're always answering emails at nighttime. We have Netflix. We have other things that impinge on our sleep quantity. So the life is very different than it was 100 years ago. And because of that, Americans are sleeping much less. From 1985 to 2012, the amount of Americans who slept less than 6 hours per night has doubled, from almost 38 million Americans in 1985 to 70 million Americans in 2012. So we sleep a lot less than we did 100 years ago. And a lot of that has to do with our lifestyle and how the world is changing. Many people may think that, sleep is a passive process, right? You're not doing anything during sleep. You're resting, but actually I would argue that it's not a passive process. It's a very active process, because when you sleep, you're consolidating memories, you're consolidating new information that you've learned throughout the day. You're regulating your mood. Sleep also regulates metabolism and appetite regulation. It affects your immune system and hormone function, and it can affect your cardiovascular health as well. Just a quick couple of slides on the basics of sleep. You have 4 stages of sleep: stage 1, 2, and 3, and then rapid eye movement sleep. So stage 1 is your lightest sleep stage. It represents about 5% of total sleep, and this is basically your transition from wakefulness to sleep. Stage 2 is where the highest predominance of nighttime sleep occurs. Almost half of the night is spent in stage 2 sleep. This is a pretty lighter stage of sleep, but this is where memory consolidation and synaptic modulation occurs. So when I say the word synaptic modulation, when your brain creates new memories, when you consolidate learning, your synapses have to be rewired. Your brain is getting rid of information that's not useful to you and retaining information that is useful to you. And this happens in stage 2 sleep. Stage 3 sleep comprises about 20% of the night. It's our deepest sleep stage. This is where physical restoration occurs, energy conservation, and also more synaptic homeostasis. Stage 3 is the sleep that increases in duration following periods of sleep deprivation. So when I work in the intensive care unit over a period of a few nights, and I work the night shift, when I get my recovery sleep, when I have a few off days, my stage 3 sleep will be significantly higher than on days when I'm sleeping. And then the last stage is our rapid eye movement sleep. You spend about 20 to 25% of your night in rapid eye movement sleep. And most people think that REM sleep is our deepest sleep. And that's probably because you lose muscle tone during REM sleep. You're not having any muscle movements, but actually your brain is the most active during rapid eye movement sleep. And this is when you dream. Rapid eye movement sleep is important for emotional regulation and memory consolidation. And you have a strong activation of your limbic system, which suggests the role of REM sleep in processing emotion. So REM sleep is actually a very active process. This is a very important graph to show us how we initiate sleep. So the top line in green is sleep pressure. So sleep pressure is essentially the body's natural tendency to fall asleep. So as you can assume, when you wake up first thing in the morning, your sleep pressure is pretty low, right? You don't want to go right back to sleep when you wake up after a full night of sleep. But as the day goes on, your sleep pressure is increasing. And this should coincide roughly with your body's natural circadian rhythm, in which melatonin is secreted at nighttime. So we should be timing our sleep pressure with the body's natural release of melatonin at nighttime in order for us to initiate and maintain sleep. Sleep pressure is influenced mostly by adenosine, which is a compound in our body. One of the major blockers of adenosine is something that most of us ingest every day, and this is caffeine. Okay, so if you have coffee at 3 p.m., what is that going to do to your sleep pressure? It's going to decrease your sleep pressure. And then when your body has its circadian rhythm that tells you need to go to sleep, your sleep pressure may not coincide with your natural tendency to fall asleep. Another thing that can reduce sleep pressure is naps. So if you take a nap at 3 p.m. in the afternoon, your sleep pressure is going to decrease, and it's going to be malaligned with your body's natural circadian rhythm. So it's important to be mindful of sleep pressure throughout the day. Caffeine and naps are 2 things that reduce sleep pressure. So natural sleep occurs 1 to 2 hours after the body begins to secrete melatonin in preparation for sleep. The vast majority of people, maybe 80 to 90%, have a what I would call normal circadian rhythm. And having a circadian rhythm that's not normal doesn't mean you're abnormal. It just means that it's slightly different than the vast majority of people. And the vast majority of people have a natural melatonin rise around 9 p.m. and then sleep occurs by 10 or 11 p.m. So night owls, people that prefer to go to sleep in the early morning hours, have a delayed melatonin rise, which usually occurs in those early morning hours, and then they will go to sleep around 1 to 2, maybe even later in the morning, in the early morning hours. Those are your night owls. And then morning larks, so early morning risers, have a natural melatonin rise that occurs in the late afternoon or early evening, and they have a propensity to go to sleep around 8 p.m. and wake up around 4 a.m. So those are your morning larks. So you have 3 different circadian rhythms: a normal circadian rhythm, a delayed circadian rhythm, which are your night owls, and an advanced circadian rhythm, which are your morning larks. So the body's inherent circadian rhythm can become a problem when it clashes with societal or familial obligations. We most commonly see this in our teenage years when we go to school. So the vast majority of teenagers have a delayed circadian rhythm. They're night owls. They tend to go to bed much later and sleep in until the early morning or the late morning or early afternoon. This is a problem when school start times are at 7 and 8 a.m. These children go to bed at midnight, 1 a.m. They have chronically insufficient sleep because they have to wake up to go to school. And then on the weekends, they have catch-up sleep, and they'll end up sleeping 10, 11, 12 hours because they have insufficient sleep during the week. This is also common in adults with shift work sleep disorder. This is just a picture showing that green is a usual amount of sleep, 7 to 8 hours, the green bar. But if you have delayed circadian rhythm or are a night owl and you have to wake up early to go to work, your sleep is shortened by 3 to 4 hours. You have chronically insufficient sleep. So then we talk about how does short sleep, less than 7 hours per night, how does it affect our health? It's been associated with higher incidences of obesity, type 2 diabetes, high blood pressure, coronary artery disease, and stroke. So sleeping less than 7 hours a night has significant effects on your health. Over periods of prolonged sleep deprivation, our body requires an increase in energy intake to maintain energy stores. And your body will also have a tendency to try and reduce energy expenditure. So if you sleep 4 hours a night for 3 to 4 nights, you're going to be less likely to want to go to the gym or to exercise because your body wants to conserve energy in periods of sleep deprivation. This is influenced by hormones at a cellular level that are naturally balanced during periods of normal sleep. This is leptin and ghrelin, which control our appetite. And then more simply, sleeping less gives people more time to consume excess calories and engage in sedentary activities in the late night or early morning hours in which they should be sleeping. So type 2 diabetes is a major risk factor for cardiovascular disease, and it can be preventable, unlike type 1 diabetes. Short sleep has been associated with glucose intolerance, insulin resistance, and a diminished response to insulin when faced with a large glucose load. And the interesting thing is, when adequate sleep is restored after a period of sleep deprivation, all of these issues with controlling glucose are fully reversible. An interesting study that happened maybe 20 to 30 years ago, 7 healthy volunteers underwent sleep deprivation. So for 4 nights, they slept for 4.5 hours. And then for 4 nights, they slept 8.5 hours. So 4 days of short sleep and 4 days of normal sleep. Their caloric intake and the frequency of meals was kept the same during each period. And at the end of each period, they underwent a glucose tolerance test. And this study actually found that after the sleep-deprived period, our body's response to insulin, which is the hormone that maintains and regulates glucose, was reduced by 30%. So you become considerably less sensitive to your body's natural hormones that metabolize glucose when you're sleep-deprived. And then you might have a question, this is a heart lecture. This is sleep and heart health. How does diabetes affect our heart? Well, When you have abnormal glucose control, our cells, and specifically our red blood cells, become glycosylated. Essentially, they have a sugar molecule attached to them. And when they travel through the blood vessels, they may cause damage to the interior lining of the blood vessels, which predisposes you to high blood pressure due to arterial narrowing. Okay. High blood pressure causes the heart to pump against a higher resistance, so you get thick heart walls, which can later lead to heart failure. And you can also have plaque formation from the damage that's done to the blood vessels from these red blood cells that have a sugar molecule attached to them. So diabetes and heart disease are very linked, and it's very clear that sleep affects our ability to control glucose. There's a 10% greater risk of developing high cholesterol in patients who sleep 5 hours or less. And there's also an increase in risk of coronary calcifications for those people who sleep less than 5 hours per night. This risk actually continues to increase by 33% for every hour of sleep that you lose. And the effect of sleep deprivation on coronary calcification of coronary artery disease is almost twice as strong for women compared to men. And we don't know the medical reason for this. This is just an association that has been reported. Patients who sleep less than 6 hours per night are more likely to experience an episode of coronary artery disease when compared to those that sleep 6 to 8 hours per night. The average increase in this risk is almost 50%. And the risk is further enhanced if your short sleep time is also associated with poor quality of sleep. For example, if you sleep less than 6 hours per night and you have obstructive sleep apnea. So we've talked about short sleep. Now we should talk about obstructive sleep apnea. Obstructive sleep apnea is a repetitive and reversible airway obstruction that occurs during sleep and causes oxygen desaturation, or a drop in your oxygen levels, or frequent awakenings. Or they can have both, frequent awakenings and drops in your oxygen level. This affects your quality of sleep significantly. So on the left, you see what we're circling as a non-obstructed airway. So air can enter your airway through your nose or your mouth, and it needs to travel into your lungs through your trachea. The most common reason for airway obstruction is that your tongue muscles relax, and the back of your throat actually collapses on your upper airway. And this restricts airflow, causes snoring, gasping, frequent arousals, and if it's very severe, it can cause a drop in oxygen levels. This is pretty technical, but this is what I see on a sleep study when someone has obstructive sleep apnea. So in the circle, you see that it's basically flat lines. That's respiratory effort in the upper airway. And these large black lines on the bottom line, that's actually snoring. So you can see that when you have cessation of airflow, this is followed by a loud snore and abrupt arousal that has to restore normal breathing. So every time you have an apneic event or a period of reduced airflow at nighttime, your body has to sense that. It brings you out of sleep to awaken you and restore normal breathing. So as you can see, if you have obstructive sleep apnea, your sleep quality can be pretty poor. It's a highly prevalent disease. So 25 to 35% of adults in the United States have obstructive sleep apnea. A recent study in the Lancet of Respiratory Medicine in August of 2025 predicted that the global burden of obstructive sleep apnea will significantly increase over the next 3 decades. And the prevalence of obstructive sleep apnea in the United States is expected to increase from about 35% of people to nearly half of all Americans in the next 30 years. They suspect an increase of almost 80 million cases of obstructive sleep apnea in the next 30 years. So obstructive sleep apnea is a highly prevalent disease, and it won't go away. We only expect that the disease burden is going to get worse. Obstructive sleep apnea is independently associated with high blood pressure, stroke, coronary artery disease, heart failure, and cardiac arrhythmias such as atrial fibrillation. It's also been associated with metabolic disorders such as type 2 diabetes and obesity. Like we talked about before, obstructive sleep apnea causes intermittent drops in oxygen levels, which causes stress on the heart. The heart is like any other organ. It needs oxygen to be able to function appropriately. And this stress also wreaks havoc on the blood vessels, which causes thickening of the arterial walls, predisposes you to development of plaque coronary artery disease, and high blood pressure. When you sleep, your fight or flight system should be quieted. Right? You should be very relaxed. Your fight or flight system is called the sympathetic nervous system. But what actually predominates when you're sleeping is something called the parasympathetic system. But when you have obstructive sleep apnea, the sympathetic nervous system or your fight or flight system predominates because you're not breathing well. Your body senses low oxygen. You sleep lighter because you need to be easily aroused to restore normal breathing. And this heightened sense of arousal and exposure of the body to adrenaline at nighttime is something that occurs in obstructive sleep apnea, but usually does not in patients who sleep normally and breathe well. So how do we test for obstructive sleep apnea? Patients with common symptoms associated with obstructive sleep apnea can obtain a portable home sleep study or an in-laboratory sleep study. Portable sleep studies are less accurate, but if they give you the diagnosis of obstructive sleep apnea, it certainly is enough. So I would argue that one is not better than the other, but if you had a negative home sleep study and still were sleeping poorly, I would certainly follow it with an in-laboratory sleep study. And the common symptoms associated with obstructive sleep apnea can be loud snoring or gasping, choking arousals at nighttime. Actually, the most sensitive finding and the most likely symptom that is related to actually having obstructive sleep apnea is when your sleep partner says that you stop breathing at nighttime. So witnessed apneas are highly associated with obstructive sleep apnea. And these patients are very sleepy during the daytime. They have unintended sleep. They can sleep anywhere. But that's not you don't necessarily have to have daytime sleepiness. It may also manifest as fatigue or low energy. So this is just a picture of what a home sleep study looks like. So as you can see, this gentleman is actually sleeping in his own bed at home with a sleep partner next to him. And there's a small kit that he has to apply himself. That's a small chest, a belt essentially, that detects for respiratory movement in the chest, a small cannula in the nose, which detects flow in the upper airway, and then a small oxygen sensor on his finger. So what he will do is he'll put this on, get in bed, turn the machine on when he falls asleep, turn the machine off when he wakes up, and then return the kit to the sleep clinic where he picked it up. And then your physician would review the sleep study and determine if you have sleep apnea. An in-laboratory sleep study is a little more complicated. So you have a sensor in your nose to determine upper airway flow. You have two belts, one on the upper chest and one on your abdomen to detect chest movement and diaphragmatic movement. You have sensors on your head to determine the electrical activity of your brain, so we know exactly what sleep stage you're in. You have a sensor on your finger as well, like the home sleep study, so that we can detect oxygen changes in your blood. You have sensors on your limbs to detect limb movements, and these are all connected to a box that is transmitted to the sleep technologist. So as you can see, an in-laboratory sleep study is way more in-depth than a home sleep study, but both can give you the diagnosis of obstructive sleep apnea, and you can be started on treatment depending on what. How do we treat obstructive sleep apnea? So CPAP is the most common therapy. CPAP stands for continuous positive airway pressure. And essentially what CPAP does is it acts as a pneumatic splint to split your airway open at nighttime, so you do not have that reversible airway obstruction that is commonly seen in obstructive sleep apnea. I have patients tell me many times, oh, I can't sleep with that Darth Vader mask, they call it, or I've also seen a CPAP mask referred to as an Air Force helmet. We actually have much sleeker and slimmer masks right now, some that go just on the nose. If you're a mouth breather and you're more comfortable, we have many different masks. There's hundreds of different types of masks. So I would not let the mask dissuade you from trying CPAP, because we know that if someone can tolerate CPAP and use it during all sleep periods, we can resolve the majority, if not all, of the obstructive events that happen at night. So CPAP is usually the first line therapy for patients who are diagnosed with obstructive sleep apnea. If you have mild to moderate obstructive sleep apnea, you may be a candidate for a mandibular advancement device. So remember from the previous few slides when we showed the picture of obstructive sleep apnea and airway obstruction. On the left here, you'll see that the narrowed airway is at the base of the tongue. So what a mandibular advancement device does is it shifts the lower jaw forward ever so slightly by a few millimeters, and it prevents the collapse of the tongue on the upper airway. So it relieves obstruction, and this is very good for patients with mild to moderate obstructive sleep apnea, but perhaps not quite as good for patients with very severe obstructive sleep apnea. So this is something that your physician may offer you depending on your sleep study results. There are patients who, when you do a sleep study, we find that sleep apnea is only present when you lie flat on your back. So if that's the case, you may even be a candidate for a side sleeping device, which is essentially a small backpack that prevents you from rolling onto your back at nighttime. So you breathe better on your side rather than lying flat, and upper airway obstruction is probably more common when you lie flat on your back than it is when you lie on your side. So we talked about short sleep and its effect on many different things: type 2 diabetes, obesity, high cholesterol, coronary artery disease. And we talked about obstructive sleep apnea and its effect on the cardiovascular system as well. But in general, what are some tips for quality sleep? It's very important to keep the same sleep schedule, even on weekends. And I would argue that keeping the same rise time is much more important than keeping the same bedtime. And I'll say this because if you wake up at 7 a.m. every day, your sleep pressure will build throughout the day. And if you go to sleep late one night, your body is much better equipped to handle one night of sleep deprivation rather than many in a row. So if you go to sleep late, but keep the same rise time, the next night you'll be able to go to sleep very easily because your sleep pressure will be much higher. But if you sleep in, if you usually wake up at 7 a.m. and sleep in till 10 or 11 a.m. on the weekends, your sleep pressure will not be as high. You'll not be able to keep the same bedtime, and it starts a vicious cycle. So I would argue that it's very important to keep the same rise time and the same bedtime if you can, but get out of bed at the same time every day. I think that will give you the most benefit. And it's also to be mindful of your inherent circadian rhythm. So if you're a night owl, your body's natural propensity is to go to sleep at 1 in the morning and sleep till 9 a.m. That's totally fine, especially if you're retired and you can, go to doctor's appointments in the afternoon, and if you don't mind that lifestyle. But it certainly can become a problem if you work the night shift or if you have other obligations that impinge on those sleep types. So just be mindful of your inherent circadian rhythm, whether you're a night owl or a morning lark, or you have the usual circadian rhythm. It's important to avoid large meals or exercise in close proximity to bedtime. So I usually say about 3 hours before your usual bedtime, try to avoid a large meal and try to avoid exercise so close to bedtime, because this will alter your body's natural propensity to sleep. And like I said before, be mindful of sleep pressure, okay? Try to avoid naps as much as possible in the afternoon because your sleep pressure will not build and you'll be unable to go to sleep at nighttime. And try to avoid caffeine in the afternoon or the evening. We recommend the last cup of coffee or the last caffeinated beverage to be almost 10 hours before you go to sleep. And I would try my best to avoid the use of television, your cell phone, your laptop, or other forms of light at nighttime. The reason being is blue light limits the body's rise of melatonin. So you'll limit your own melatonin production, and you will be unable to match it with your sleep pressure if you're spending an hour, 2 hours watching TV, reading on your phone in bed at nighttime, or working on your laptop. So I would avoid the use of all of these things at nighttime. If you feel your circadian rhythm is misaligned with work, familial, or societal obligations, and this causes distress to you, please consult with your physician about strategies to combat this discrepancy. Certainly a sleep medicine physician will be able to help you with this. And a lot of the treatment strategies center around exogenous melatonin. So you can take some low dose of melatonin, bright light early in the morning, but I would only do this under the advice of the physician. And if you snore loudly, have choking, gasping, arousals, number one, I would avoid sleeping on your back. I certainly would not drink alcohol before bedtime, and alcohol is should always be consumed in moderation. But alcohol 3 hours before bedtime certainly can make snoring, and if you have obstructive sleep apnea, it can make sleep apnea worse. And I would consult with your physician to consider a sleep study to be evaluated for obstructive sleep apnea. And as always, it's important to maintain a healthy weight. And I think that's all I have. Here are my sources. I know I went through that kind of quickly, but it does open us some time for questions, and I'm happy to do that.
Yes, thank you. We have a few questions, so we'll get to those. Let's see. The first one, there was a graph you had on one of your slides, and it showed that the sleep pressure bar rises over 36 hours, not 24. Can you explain how that works?
Yeah, so you'll see that adenosine, the natural rise is after 36 hours. This has to do with your body's ability to break down adenosine. I would focus on the right side of the screen. Quite honestly, I disagree with the left side of the graph. But essentially, what you want to do is have the right side of the screen happen. It wants you to time up sleep pressure with your body's circadian rhythm and melatonin. So that was a good catch. And I would agree with you that I kind of disagree with the left side of it.
Thank you. I had a couple questions about what accounts for the projected or expected increase in sleep apnea. If you can talk a little bit more about that.
A lot of it has to do with obesity. So obesity is a very common predisposing factor to obstructive sleep apnea. A lot of it has to do also with under recognition. So I think that as doctors, we don't do a very good job of screening for obstructive sleep apnea. And certainly sleep is not something that I feel patients openly speak to about their doctors. You know, there's many other medical issues that you need to speak with your doctor within 15 to 20 minutes. And sleep is not always first on the list of things. So I think it has to do with the rising rates of obesity most commonly, and it also has to do with under recognition on outcomes.
Thank you. Now, any thoughts on tongue retaining devices and implants for apnea?
Tongue retaining devices and implants.
Yes.
I'm not very familiar with those, but what we do have coming out on the market is an electrical stimulator that you can apply into your mouth. And what that will do is strengthen the muscles that keep your tongue protracted, which essentially prevents the tongue from collapsing on the upper airways. I'm not terribly familiar with tongue retraction devices, and I certainly I don't know if I would recommend them because they're not quite in the medical literature and guidelines for obstructive sleep.
Thank you. I believe you did touch on melatonin, but we have a question. Do you recommend using melatonin tablets to induce sleep? If so, how much and when should you take it?
So melatonin is basically, by the medical community, is recommended in two different sleep states, I would say. I wouldn't call them diseases. Sleep conditions maybe is a better word to describe. And one is a malaligned circadian rhythm, and most commonly night owls. So in someone who's a night owl, I would recommend a very low dose of melatonin, maybe 0.5 milligrams to 1 milligram, a few hours before your intended sleep time. And that, coupled with bright light first thing in the morning, a strict sleep schedule, it may be able to shift the body's natural circadian rhythm forward a little. The other thing melatonin is useful for is jet lag. So in patients who fly frequently across multiple time zones, melatonin can be useful to manipulate the circadian rhythm. But usually I recommend melatonin in very low doses and only for these two sleep conditions. There was actually a study that looked at different over-the-counter formulations of melatonin, and they found that the dosages are very arbitrary. So for example, if you took a 5 milligram bottle of melatonin and actually analyzed how much melatonin is in each tablet in that bottle, it would range widely from 1 milligram to 10 milligrams. The bottle may say 5 milligrams, but what each pill has, we don't really know. It's very unregulated. So I would take melatonin in the smallest dosage 0.5 to 1 milligrams, and for those two conditions, usually delayed circadian rhythm and for jet.
Thank you. That's good information. Sorry, this one we did answer already. A couple questions we're asking about the projected increase, which you answered. So what do you think about devices such as Fitbit accurately assessing your quality of sleep?
It's a great question, and it's something that's becoming a lot more prevalent with the use of sleep wearables. So Fitbit and other things like the Whoop, perhaps, they use something called arterial tonometry to estimate sleep stages. So when your Fitbit says that you're in REM sleep, we don't know for sure that you're in REM sleep. Fitbit will estimate REM sleep by your oxygen levels, your heart rate, and your body movement. So in REM sleep, your body is not supposed to move. So the Fitbit will estimate the amount of REM sleep based on these things. I think it's good as a screening tool. It can identify a sleep problem or hint towards a sleep problem, but I don't think we can make any diagnoses based off of the Fitbit. I think if you're having sleep issues, if you suspect something's wrong based on what you're seeing from the Fitbit, you should talk to your doctor about it and consider the sleep study. I think it's useful for screening and hinting at a sleep problem, but I don't think we can make any firm diagnoses based on that.
Thank you. I have a question. Is central sleep apnea worse than obstructive sleep apnea?
So central sleep apnea is not necessarily worse than obstructive sleep apnea. Central sleep apnea is usually a secondary issue to something else, such as heart failure, stroke, medication induced. If you have chronic pain and you take pain medicines, it might predispose you to central sleep apnea. And central sleep apnea is a little more difficult to treat than obstructive sleep apnea. And the literature is a little less convincing in regards to cardiovascular morbidity and mortality, mostly because a lot of these patients with central sleep apnea already have heart failure or other issues that are predisposing them to central sleep apnea. So I wouldn't say that one is worse than the other. They are very different entities, and they are treated, they can be treated differently.
Thank you. We have a question. What is your best advice for dealing with sleep maintenance insomnia? And can caffeine early in the morning, 5 a.m., prior to working out, have any impact on this if done for years?
I would say that if you have coffee first thing in the morning at 5 a.m., it's probably going to be out of your system by the time you go to sleep. So I think you're okay having 1 cup of coffee or 2 cups of coffee first thing in the morning. Maintenance insomnia is the body's inability to stay asleep at nighttime. So I certainly would optimize sleep hygiene, right? Avoid blue light at nighttime. We always tell our patients the bedroom should be for sleep and marital relations only. We should not be working, watching TV. You can read a book for a few minutes with a dim light, but we really should be avoiding a lot of those things at night. And the general recommendation is if you wake up in the middle of the night and you cannot go to sleep right away within 5 to 10 minutes, the recommendation is to get out of bed, go do something low activity in another room of the house, maybe read a book with a dim light, and then go back to bed whenever you feel sleepy. And the point is to create an association with the bed as a place for sleep, not as a place where we're struggling to sleep. And there's something called cognitive behavioral therapy for insomnia that is very useful for patients with maintenance insomnia. And there are free programs all throughout the internet, and you certainly can do your own search for CBTI, cognitive behavioral therapy for insomnia. And this is useful to teach you about sleep and teach you strategies to combat this because it's fairly common.
Thank you. Yeah, we have a few questions about how to get back to sleep. So you kind of just spoke about that, and that's a good reminder for myself as well. Someone referenced that there are ads for sleep, like they may have seen ads, TV ads for sleep apnea medication. And what are your thoughts on those?
Sleep apnea medications. So there are some new medications that are coming through the pipeline. I think you're probably referring to the GLP-1 agonists like Ozempic, tirzepatide, Wegovy. These medications mostly reduce sleep apnea, by helping patients maintain a healthy weight. So the studies were done on these medications in patients with sleep apnea and found that the sleep apnea was actually almost cut in half. But this is mostly modified by considerable weight reduction, almost 10 to 20% of body weight reduction will reduce sleep apnea. So I believe that these medications are useful for obesity to maintain healthy weight, and then as a secondary benefit, it will reduce sleep apnea. I do not think it's something that will cure sleep apnea, but probably will help in overall severity. Then there are other oral medications that are being researched now as a supplement to CPAP and sleep apnea. And those, again, may help with severity of sleep apnea as well, but there are no oral medications that can cure sleep.
Thank you. Are the treatments for sleep apnea short-term or long-term, or does it depend on the individual?
So yeah, that's a good question. It depends on the individual. Most patients with obstructive sleep apnea are probably looking at long-term treatment with CPAP. Really where we see CPAP being used in the short term is someone who undergoes bariatric surgery and has significant weight loss, at which time we may retest them and they may or may not have a significantly reduced severity of obstructive sleep apnea, or it may be resolved. But the vast majority of patients with obstructive sleep apnea are probably looking at long-term therapy.
Thank you. I believe that was our last question. So if no other questions kind of pop into our Q&A box right now, I will thank you for everyone joining us on this Sunday afternoon. And thank you very much, Dr. Wojnowski, for all this good information. I hope everyone will get a good night of sleep tonight and put some of these things to great use. So thank you very much for your time and your expertise today.
Thank you.